Welcome everybody again to another episode of the ideaXme show that profiles the humans behind the really big ideas that are shaping our world, inspiring the future and future creators, and for all those that like really great stories. I'm Ira Pastor, your life sciences ambassador along for this journey. Today we are going to head into the fascinating intersection of death, dying, and dreams. I'm really honored today to be joined by Dr. Christopher Kerr, who is the Chief Executive Officer and the Chief Medical Officer at the Center for Hospice and Palliative Care in Buffalo, New York. Dr. Kerr joined Hospice Buffalo back in 1999 as a medical director for one of the organization's inpatient units, and he served in that capacity till 2011 when he was appointed as Chief Medical Officer, and he was ultimately named Chief Executive Officer in 2017. Dr. Kerr's background in research, which is originally at the bench, has evolved towards studying human experience of illness as witnessed from the bedside, specifically related to patients' dreams and visions at the end of life, also termed end-of-life experiences, or ELEs. Dr. Kerr has cared for thousands of patients who have these remarkable stories of dreams near the end of their life that are truly unlike any regular dream that you and I might have. Routinely described as more real than real, these detailed end-of-life experiences involve the resurrection of past relationships, of extremely meaningful events in one's life, as well as, encompassed by these themes of love and forgiveness. Dr. Kerr's research has studied over 1,400 patients, which has revealed that these pre-death dreams and visions are really extraordinary occurrences that, when studied in close detail, really show sort of the humanization of the dying process. Dr. Kerr has an undergraduate degree in psychology. He's an MD. He has a PhD in neurobiology and completed his residency in internal medicine at the University of Rochester. He's received numerous awards, has recognized his clinical performance, both as an educator and a scientist. He's recently published a book, Death is But a Dream, Finding Hope and Meaning in End-of-Life Dreams. And also there's now a documentary coming out about him and his practice with the same title. Results of his studies have generated an enormous amount of response from the non-medical community, both nationally and internationally. Coverage has included the New York Times, Huffington Post, BBC, Scientific American, Psychology Today. Dr. Christopher Kerr, thank you for taking the time to come on the show today and talk for us for a little while.
Thanks for having me. Appreciate it.
And it's a real pleasure. Typically start off the show by giving our guests the floor just for a little bit. If you could talk about yourself for a few minutes, your background, sort of where you grew up, how you got interested in psychology and medicine, and ultimately what brought you to hospice care, which is, as you said in other presentations, is an area where 100% of your patients are going to die. Take us a little bit down that path, if you would.
Sure. Born and raised in Toronto, Canada. I'm still Canadian. All my relatives are there. I'm the son of a physician and a psychologist. So I kind of always had that exposure. And actually many of my forefathers and aunts are doctors as well. So it's kind of what I knew. And was shown what a privilege it was, and that's kind of the direction I always wanted to go. I ended up in hospice care. I wish I could tell you it was something big and aspirational, but I was actually a cardiology fellow and pretty happy on the acute side, interventional side of medicine, but I needed extra money to support my family while I was a fellow, and saw an ad in a newspaper asking for a hospice doctor. Answered the ad and came here. And after doing this for probably, 4-6 months, I just felt it was some of the most meaningful work that I'd ever done. And I made the change. And 21 years later, I actually can say I've never looked back with any sort of regret. There were a lot of reasons for it. I think the best instincts that you go into medical school with are preserved and protected in this work. You get to be really present at the bedside, know patients as people in the context of their lives, and treat them in totality as all those things that really seem to matter, and make it more rewarding. I ended up doing this sort of research really again, not having any sort of leaning towards this. In fact, kind of the paranormal and existential probably make me more uncomfortable than comfortable. But what happened was, when I got here, I quickly realized that the dying included this non-physical dimension, that it naturally draws people inward and to reflect and to be introspective. And that these experiences not only mattered and gave people meaning, but they were therapeutic. They provided great comfort. And then kind of what happened was I was frustrated trying to teach other young doctors the importance of these experiences. And their retort was always, well, there's no evidence for this, and we live in a evidence-based time. So I just started to do some studies, very formalized. I ruled out confusion. I videotaped many patients, standardized questionnaires, published in peer-reviewed journals. And an interesting thing happened, which was I got zero response from the medical community. But it leaked out in the non-medical community, and it literally went around the world. And what was interesting in the response was they weren't necessarily responding to me per se, which was fine. It was validating something they had witnessed, and that for the first time had been given some context in a way they could make sense of, so that this had definition for them. So that's basically the long and the short of it. Was the work has really been propelled by the fact that this mattered to people who had had similar experiences.
Outstanding. It's not, yours is not the first time that we hear, and we have guests on the show about sort of this fascinating area of exploration that, there's some folks over here that say, no, don't do that, because as you were saying, this is hallucinations, or this is some altered metabolic state. And it's, I sit back and I hear your story, and I hear some of the other stories. We did a show on a couple of episodes ago on delirium, which is another area that it's shocking just how much money we spend on this particular state, but no one really studies it. And I think it's not like you're trying to study perpetual motion or faster than light travel. I mean, these are real experiences. Before we go into a little bit, what are some of the it's sort of the negative feedback from the medical community when you talk? What is it just that they're so afraid of getting their feet wet in this stuff because it's there? What is some of that? Where does some of that come from? Because I remember there was also something in the TED talk that you gave recently where sort of you were exposed to it by, I think it was a story about a nurse or something that was telling you, doctor, we're not going to give any more care to this patient because they're going to die soon because of their dreams. So take us a little bit into sort of the pros and cons that you see when you're trying to do this work. I think it's really a fascinating part of the story.
It was a couple things. Yeah, I was certainly on that side of the fence. I think medicine's uncomfortable with anything that it can't concretize, can't objectify, can't measure, dissect, take an image of. And its quest is always to give definition, and that's very hard to do with things that are unseen. That's one. The whole topic of death is become progressively more difficult for medicine, particularly Western medicine. It's the enemy to be fought. And if we're uncomfortable with death, we certainly aren't going to lean into the experiencing of it from the patient's perspective. I think we have kind of a health industrial complex that basically takes the physician farther from the bedside when they're no longer curative. So it's not enough just to be a comforter, to provide comforter or presence to a dying patient. So we essentially have self-sterilized ourselves from the process. Very interestingly, you mentioned delirium. Medicine's more comfortable with the brain than it is the mind. And whenever there's challenges to the mind, it's very easy to put it in this black box of altered states like delirium. So we're less comfortable with again, these more soulful processes that just exist as part of our human experience. We we accept that there's love, even though we don't put it through a scanner, but that there's also these experiences, which is so unusual because dying is a vantage point that naturally changes your perspective, your perception. You're not worried about taxes and where your keys are, etc. You reflect on the things that matter naturally. But we don't, we just have such a hard time with dying. Yeah. Those are a few reasons.
No, I appreciate that. That's why I wanted to sort of lay the background with that, because I think it's important, sort of, as you've been doing this.
The other interesting thing that I run into and have run into is there's a temptation when you're looking at dying to view it as a keyhole through which to view the afterlife.
Yeah.
And whether that be paranormal, religion, what have you. And we weren't interested in that at all. Right. What we want to do is look at dying as a mystery unto itself, simply translate the words of people who were dying without editorializing on their translation or meaning.
So there's a wonderful quote on I don't know if it's the documentary site or your book, but it goes, dying is a paradox. You say physically you're declining, but spiritually, emotionally, you're vivid, alive, and present. And then you talk about this sort of phrase that you repeat quite often: these dreams seem more real than real. You explain they're extremely detailed. There's common sort of themes in a lot of them, in terms of reunions, in terms of guidance, in terms of next steps. Talk a little bit about what more real than real means. Once again, I'm sorry, putting this context of thinking about the delirium discussion from a few weeks ago, but thinking about that state where, total confusion, but here is something with total clarity in many ways.
Yeah, thank you, because that's really important. So delirium is an altered sensorium. So your thoughts are actually highly disorganized, to the point that you have no acuity, you can't make sense of things, right? It's random motion, essentially. People who are having end-of-life experiences actually are highly organized. If anything, they have heightened acuity. More real than real is actually what we're told. So in our first study, we would ask people daily until death about these experiences, and we had a Likert scale of 0 to 10, and 10 being the most real, 0 being the most unreal. And far and away, 10 was the most common number that was chosen. And the things we hear from the patients were, you don't understand, I don't normally dream, or I don't recall my dreams. This was more than that. This was virtual. This felt lived. This was like a memory. So it's funny because we refer to them dream because that's the only nomenclature or reference point we have, but our patients are actually saying they're not like their normal dreams. So more real than real is kind of one of the ways we describe them. In terms of the paradox of dying, it really is interesting. We are so overwhelmed as observers to dying by what we see, which is physical lessening, and our feelings of grief and loss, anticipatory feelings of grief and loss. Yet the patient side is having this very active inward process. And when we looked at these experiences as post-traumatic growth, so the trauma being dying, and to see whether there was growth processes in these, people who are having these experiences were actually growing in terms of insight and adaptation. So right up into their last days, they don't stop living because they're dying. They're actually having very profound experiences.
Moving on from that, then, you write about the benefits of these, and there's benefits that you mention in terms, obviously, for the person dying, the comfort, the sort of happiness, the positive emotions, and at the same time, you write about they also bring, obviously, comfort to the families, because one wants to know that their loved one is happy, or leaving this place, whatever the scenario is, that it helps the accepting of the loss at the same time. Can you take us down just a little bit about both of these paths, if you would, because I think they're both very important points.
Sure. From the patient's perspective, there's some themes that emerge, and far and away, the one that seems to give them the most comfort is reunion with those who they've loved and lost. And they're not just random. They're key critical people who either loved you, secured you, loved you unconditionally. Those are the people that tend to recur. When we measured comfort on a 1 to 5 scale, that was close to 5 across the board. And those actually increase in frequency as you get proximate to dying.
Mm-hmm.
So there's like this built-in mechanism. There's also very distressing dreams in about 17%, but those are actually some of the most transformative. There's a need to either let go or to address a regret or to be forgiven. That sort of thing that gets addressed. These processes don't deny the life. They end up kind of reaffirming the best parts of having lived. In terms of the bereaved, we've done a lot of studies on this, and probably now we're over 750 interviews or surveys, what have you, with people who have experienced loss. And actually, they're probably some of the most powerful videos, I think, as powerful as the patients. And, it comes down to a couple of things. You're looking at your loved one and their eyes are closed. Our concern goes to where are they? How are they? And you can either see emptiness or you can see connectivity to people they love or shared experiences. A couple who lost a child and she's holding the baby and talking to the baby. Things like that. It matters how we see people die. And if we see them die in comfort and in love, then that's how we remember them. And when we've looked at this and actually looked at grief scales for people who are bereaving somebody, people who have shared in these experiences grieve differently.
Sure.
They remember, they recall differently. It can be anything that brings kind of a positive to this that changes how we view it.
Another sort of quote I read had to do with these stories from the patients pointing not to death as just the end of life, but about and quote a final chapter of humanity's transcendence. We're not talking about the spiritual stuff here or afterlife or paranormal, but take us a little bit of what you feel that means, what we want to get out of that, if you will.
Yeah, I think that it's less of an end point and more of a point of connectivity, whether across lives, whether living or dead. And you're forced to kind of reconcile with this when you see somebody who's 95 who may have lost their mother when they were 5, but it's her voice they hear and it's her perfume that they smell. So yeah, it's this idea of transcendence. It's, again, death isn't being denied here, but life is being valued here. And I think that changes it dramatically. And just this reminder that in some ways that the best parts of having lived aren't necessarily lost.
Sure.
Time seems to be absolutely irrelevant. It's these key critical moments and relationships in life. And again, some of them are traumatic. War is traumatic. Lots of veterans who have had survivor guilt or PTSD and may have gone 6 decades with this, but that somehow gets addressed. It's this idea of somehow being made more whole in the end. We all have been harmed for having lived, and often those things get addressed. A parent who is a child who is in jail questions their worth as a mother or father. But they're reaffirmed at the end. Those stories are just absolutely remarkable.
A few episodes ago, we touched on a topic in the Alzheimer's space. This sort of this weird event that sometimes occurs, known as terminal lucidity, where you may have somebody with dementia for no matter how long. They don't know who their husband is, they forget their kids' names, but there's this moment of clarity that somehow reappears before a point of death. Anything related to some of these pathologies, in the sense, this particular case, dementia, Alzheimer's, that maybe are part you see in some of these dreams, or coming through these dreams. I'm just interested in maybe how some of this stuff is connected, as in the sense you see so many patients that die different ways, let's say, or from different pathologies. Anything interesting or kind of
Yeah,
esoteric?
I actually think it's the most interesting.
Okay.
Yeah, so terminal lucidity is more than clinical lore, right? I mean, it's
Sure.
and you know, I have an interpretation of it that might be a little different. I think that clearly we access memories by different channels.
Mm-hmm.
So it's not uncommon, for example, to have a demented patient who's essentially nonverbal,
Mm-hmm.
but you play that song that was a hit in the 40s,
Yep.
and all of a sudden they can come out with rhyme. So there's different ways to access memory. I think end of life is one of those things.
Okay.
Again, changes your perspective and your perception. I think the mistake we make with people who are cognitively different is we measure them by their cognitive deficits.
Mm-hmm.
And that what that does is it disregards the fact that they might have an emotional life, an emotional history, an emotional texture to their life that gets lost. And that includes people with all sorts of, quote, disabilities. And I can give you some just striking examples. You know, we have a lady who was filmed,
Mm-hmm.
who at the end of her life was trying to get going because she had to get to her wedding. So at the end of her life, and she's reflective on really the happiest day of her life. You know, we had a woman who had Down syndrome and was naturally extraordinarily maternalistic, carried dolls with her.
Mm-hmm.
And she had ovarian cancer and had swelling of her belly. And that symbolized the baby to her.
Wow.
And so her life ended with her feeling as though she was giving life. So people have all sorts of, the fact they may not know certain facts,
Sure.
doesn't discount the fact that they're rich emotionally. They're remarkable stories of that. But this idea of remarkable recall is not surprising in some ways, given what they're facing.
Mm-hmm. Mm-hmm. Any situations, I'm thinking, you know, down here in Virginia, there's the Center for Perceptual Studies where they study these children that somehow know stuff that there's no possible way they ever learned. Any interesting things you see in terms of sort of savant type knowledge or acquired knowledge that, you know, a loved one might say, you know, don't know how they ever learned something like this, or any interesting thing on that front, and then we'll come back from
You know, I actually know clinical tales.
Okay.
But you know, that you do this for 20 years, they obviously hear stories.
Sure.
I didn't didn't come out in our research,
Okay.
per se, but yeah, lots of lore.
Gotcha. Okay.
Yeah.
Figures much. Coming back to you now, what's next in terms of new studies, new clinical programs? Anything that you'd care to talk about in terms of?
Yeah, we're doing a number of things. So we're delving deep into this idea. It's one thing to show these experiences, give feelings like comfort,
Sure,
and meaning, but also understanding what they do in terms of providing insight and understanding. So deeper, more substantive process. And again, looking at this, the grief process and how these experiences affect grief. And then developing some toolkits that help people normalize them, discussions in and around that.
Mm-hmm.
So those are the kind of things that we're working on.
Excellent. One final question. We like to sort of ask a question about influencers in our guest's career. And you mentioned early on that once you got involved in this area, you never looked back. But any specific people that you may want to mention, give a shout out to, that, you know, if it wasn't for for them along the way, you know, Dr. Christopher Kerr right now would be doing law or cardiology or something totally
Yeah,
outside.
there was my mentor, Dr. Robert Milch.
Okay.
You probably know his brother David Milch, who was like the writer producer of L.A. Law,
Okay,
Deadwood,
sure.
Hill Street Blues, all those sort of shows. So
Oh,
he
wow.
is a kind of social justice warrior surgeon who blazed a trail and really made it more acceptable for people like myself to leave mainstream medicine and do something like this. Because there's a time this was viewed as a waste of a career, and he did it at a time when it wasn't vogue at all,
Mm.
and he did it in a way that made it seem like an aspiration. The other piece of gratitude really goes to my non-physician colleagues,
Mm.
who, from music therapists to chaplains and social workers to nurses, and even volunteers who teach us well that we take care of patients in totality, and that includes all these different perspectives. Caring for the dying does not just belong to the purview of the physician.
Sure.
And they've got remarkable insights and skills that I have benefited from every day.
Outstanding. Thanks. I appreciate that.
Yeah.
Because it's been really wonderful hearing the story and everything you're doing, and really, thanking you for doing it, because I think there are these areas that are unfortunately overlooked, but can, in our learnings and what you're learning and teaching through your book and the documentary and so forth, add so much value, I think, to the future as we build it, because this is really an untapped frontier, I feel, in many ways, and just really thanking you for doing it. For everybody that's going to be watching on the YouTube channel, listening on the various podcast networks, we've been spending time with the amazing Dr. Christopher Kerr, Chief Executive Officer and Chief Medical Officer at the Center for Hospice and Palliative Care in Buffalo, New York, doing really amazing things, not just in terms of hospice care, but in studying end-of-life events, end-of-life patient dreams and visions, really teaching us a lot about humanity and what it means to be human, the death and dying process. Pick up his book, Death is But a Dream, Finding Hope and Meaning in the End of Life Dreams. Also, is the documentary, when's the documentary coming out, by the
It's
way?
coming out in the fall.
Okay.
But the best thing people can do is look at the website and look at the videos of the patients and the families. And that's drdrchristopherkerr.com.
Chris, it's a pleasure having you.
Thank
Thank you for what you do. And as we say on the show, thank you for moving the human story forward. It's really impressive work. Very impressive stuff.
Very much. Appreciate it.